Hello, good evening, everybody. Welcome to today's webinar, ILAE Africa Committee webinar. Thank you for all those who are joining us this evening. Just a few rules before we get into our webinar. If you have any questions, you're free to type them in the Q&A box. So the Q&A box is at the bottom of your screen. Feel free to type any questions that you may have as the presentation is going on, and we're going to read them out. We're going to read out your comments or questions at the end of the presentation. So just look at the bottom Q&A box. That's where you type in your questions or your comments. Again, I'd like to welcome everybody. To this session. I'd like to introduce Dr. Philip Adebayo. He's our presenter for this evening, talking on epilepsy in older people. So Dr. Philip Adebayo is an associate professor of neurology at Aga University, Dar es Salaam in Tanzania. He is also a consultant neurologist with the Aga Khan Hospital in Dar es Salaam, Tanzania. Dr. Adebayo completed his neurology training from the University College Hospital, Ibadan, Nigeria. He holds a Master of Science in Clinical Neurology from the University College, London, UK, and a Fellowship in Clinical Neurophysiology from Istanbul University in Istanbul, Turkey. Dr. Adebayo currently heads the neurology section of the Aga Khan Hospital in Dar es Salaam, Tanzania. He has published over 100 peer-reviewed articles in local and international journals. He has a keen research interest in stroke and epilepsy, in particular, the quality of life of people with epilepsy. He is passionate about neurology education, mentoring, and brain health advocacy. Dr. Adebayo, welcome and thank you for doing this presentation with us.
Hello everyone, you are welcome to this webinar. It's my pleasure to be delivering this topic, epilepsy in the elderly. I'll also want to use this opportunity to thank everyone who's been instrumental in organizing this. So let us dive right into it. I do not have any conflict of interest to declare. In this presentation, I shall cover the epidemiology, the etiologies, and peculiarities of epilepsy in the elderly, while looking at evaluation and management issues regarding epilepsy in the elderly. We're going to look at care coordination for older adults with epilepsy, and wrap it up with issues about future directions and how to improve the current landscape of epilepsy management in the elderly. So by way of introduction, we all agree that our world is aging. We have an aging population. The most rapidly growing segment of the world's population right now are individuals aged over 65 years. And the World Health Organization also has made projections of increase in the world population, especially for the cohort of individuals aged 60 years or older, to be about 50% in the next 20 to 30 years. And this cuts across every continent, including the African continent, even though the proportion of increase is way lower than other regions of the world. But again, it's expected that even the African population will also age. So it's expected now that the burden of epilepsy in older adults will likely grow with the aging population, because the current data shows that the incidence of epilepsy among persons over the age of 65 years is roughly double that among those who are under age 65 years. So we expect that the burden of epilepsy will grow. However, there remains a misperception that seizures are uncommon in the older adults. So the question then is, who are older adults, who are elderly? Actually, they are defined as individuals over the age of 60 or 65, depending on which part of the continent you are from. If you're using the United Nations age cutoff, which is 60 years, or you could also be using the age cutoff for most high-income countries, which is about 65 years. Actually, the origin of these age cutoffs are kind of arbitrary, and it dates back to the end of the 19th century, when the European countries legislated the age at which a person became eligible to receive pension benefits. So when we define late onset epilepsy or elderly onset epilepsy, generally we refer to epilepsy starting after the age of 60 years, but we should also recognize that the features of late onset epilepsy actually cut across a wide spectrum of ages. But we are dealing with large data, or there's a need to dichotomize data. We usually recommend a threshold cutoff for elderly onset epilepsy to be around 65 or even 70 years old, as the case may suggest. So let us look at the epidemiology of epilepsy in the elderly. We all know that epilepsy is commonest in the extremes of life, and the incidence rate is also highest in the youngest and the oldest, of course. It is estimated that the incident rate of epilepsy is around 1 to 3 per 1,000 person years in the elderly. So if you compare that value with the pooled incidence rate of epilepsy, which is around 0.6 per 1,000 person years, you will agree with me that incident epilepsy indeed is common in the elderly. Now, the Global Burden of Disease report on epilepsy actually shows that the incidence increases steadily after the age of 50 years, and that, of course, that the greatest incidence is in people older than 75 years. The age standardized data shows a bimodal peak, with the first peak around the age of 50 and the second peak around the age of 75. The cardiovascular health study, which is an observational cohort study of almost 6,000 mostly white older adults, also corroborates the global burden of disease data, and the incidence rate of epilepsy in that population is around 2.5 cases per 1,000 person years. So now we have seen that epilepsy incidence is highest among the elderly, and coming back to sub-Saharan Africa, we can see similar pattern with epilepsy being highest among elderly population of sub-Saharan Africa origin. I mean, considering the global burden of disease database. However, when we compare the incidence rate of different regions of sub-Saharan Africa, we can see that the incidence rate of epilepsy among the elderly is even higher than the global rate. And this cuts across most of the sub-region of sub-Saharan Africa, with southern sub-Saharan Africa and western sub-Saharan Africa having rates that are way, way higher than the global rate. So this higher rate of incident epilepsy could be attributable to the high rate of CNS infections, as well as traumatic brain injury in low and middle income countries. We should also note that there is a rising burden of stroke in sub-Saharan Africa, and this could be contributing to new onset epilepsy among the elderly in this sub-region. In the same vein, the prevalence data is showing that epilepsy is prevalent among the elderly. The Global Burden of Disease report on epilepsy gives a prevalence data of about 5.4 per 100 people. The same thing, the cardiovascular health study also shows a prevalence rate about 5.7. And so if you compare this rate with the overall lifetime active epilepsy prevalence rate of 0.76 per 100 people, you will agree with me also that epilepsy is prevalent among the older adults. Now, this prevalence rate is even higher in nursing home residents, with a point prevalence of more than 7.5%. No doubt, epilepsy is more prevalent in low and middle income countries, where nearly 80% of people with epilepsy reside. And if you look at this paper by Gupta et al., you can see that the heat map is showing the average epilepsy prevalence rate across different countries, with some countries having prevalence rates approaching 800 per 100,000 population. And of course, the temporal trends in epilepsy prevalence rates globally as well as in each region of sub-Saharan Africa shows rates that are way higher than the global rate in most of the sub-region of sub-Saharan Africa. And this is with the elderly. So we can see that epilepsy is more prevalent among elderly population of sub-Saharan African origin. Now, with regards to the disability adjusted life years, age standardized disability adjusted life years of epilepsy is around 183 per 1,000 population, with males having a higher disability adjusted life year rate than females. And a comparison with the younger population actually shows that the higher disability adjusted life years is seen in younger population compared to the older adults. Let's understand that disability adjusted life years is calculated using years lived with disability and the years of life lost. So this could also be the disparity between the younger population and the older population. So generally, the quality of life of patients with epilepsy is impaired. All right. Of course, seniors with epilepsy do not have poorer health-related quality of life compared with the general epilepsy population. However, when compared with the general population without epilepsy, elderly with epilepsy report a significantly lower quality of life across all the domains of quality of life measurements. And of course, if we look at the data from Lachio and the report by Baranowski, participants actually reported energy fatigue to be the most negatively impacted domain of quality of life in the elderly. And seizure frequency was the strongest predictor of quality of life in impairment in the elderly. So globally, mortality ratios are higher among elderly with epilepsy compared with the younger population. And of course, this similar pattern was seen in the sub-analysis of the data from sub-Saharan Africa. And we know that low and middle income countries have higher mortality rates that approaches almost 10 times that of the high income countries. And a new diagnosis of epilepsy actually reduces the survival of Medicare beneficiaries as can be seen from the paper by Blanket et al. And this is more so if such individuals or such elderly individuals have some concurrent neurological comorbidities. Let us now look at important causes of seizures and epilepsy in the elderly. The number one is cerebrovascular diseases, and it's always going to be cerebrovascular diseases. If you look at the pie chart here, you can see that ischemic stroke accounts for more than a third of the causes of epilepsy in the elderly. Now, if you include hemorrhagic stroke, that proportion actually approaches 50%. Stroke is the strongest independent predictor for both acute symptomatic seizures, in which case we say it is early post-stroke seizures, as well as new onset epilepsy in the elderly. Additionally, cerebrovascular disease and epilepsy have bidirectional relationship. Clinical stroke is known to predispose to epilepsy, just like we're saying right now. And in the flip side is that seizures in the absence of prior clinical stroke is also associated with significantly elevated risk for stroke. Another important cause of epilepsy in the elderly is neoplasm, and this could be primary or secondary CNS neoplasm. And of course, both could present with acute symptomatic seizures as well as epilepsy. And of course, with regards to the primary CNS neoplasm, the frequency of seizures and epilepsy is highest in the elderly with low-grade astrocytoma compared to anaplastic astrocytoma. Again, another factor is traumatic brain injury. Older individuals are more vulnerable to traumatic brain injury, again, because of the increased risk or false. And because brain injuries are often followed by a latent period of time before the appearance of recurrent seizures, a remote history of injury, even trivial injuries, are quite important when we are, taking the history of elderly with epilepsy. Neurodegenerative conditions, especially Alzheimer's disease, are equally an important cause of epilepsy in the elderly. Neurodegenerative diseases are predisposed to epileptogenesis because of various CNS structural as well as biochemical changes. And patients with familiar early onset Alzheimer's disease tends to have very high risk of seizures compared with age-matched controls. Another point to note is the bidirectional link between Alzheimer's disease and epilepsy. Formerly we used to think that seizures were epiphenomena, a consequence of neuronal loss in the degenerative hippocampi. However, it now seems that epilepsy itself might be contributing to the pathogenesis of dementia, especially in Alzheimer's disease. Although the exact mechanism remains yet to be elucidated, but I think this will be an interesting subject of future researches in trying to see the link between the two conditions. Now, the risk for epilepsy in Alzheimer's disease tend to equate that of vascular dementia. Patients with frontotemporal dementias have, about 2%. About 2% of people with frontotemporal dementias are reported to have seizures. Now a note on causes of acute symptomatic seizures in the elderly, which is seizures presenting in close temporal association with a brain insult. Here we can see that early post-stroke seizures leads the pack in almost half the cases. Of course, we shouldn't forget acute metabolic illness, electrolyte disturbance, toxic etiologies, recent traumatic brain injury, CNS infections, which is actually very common in sub-Saharan Africa, as well as other causes, such as subdural hematoma, are important, causes for acute symptomatic seizures in the elderly. Now, as we look at presentations of seizures in the elderly, we should be aware that the presentations of seizures in the elderly are quite different from the younger population with epilepsy. Now, we look at different seizure types, but of all the different seizure types, focal impaired awareness seizures leads the pack. In more than 50% of cases. Of course, they could have other seizure types like generalized tonic-clonic or focal to bilateral tonic-clonic, as well as focal aware seizures. Of course, there could also be generalized epilepsy, and this could be in elderly with early onset epilepsy that have gone into remission and now they are having a recurrence later in life. Or they could actually have late onset generalized epilepsy. But we should note that generalized epilepsy of presumed genetic origin is quite rare in this age, but few reports have been found in the literature. Now, status epilepticus also is one form of presentation of epilepsy or seizures in the elderly, in which case about 30% of epilepsy presents as status epilepticus in the elderly, with increased mortality which approaches 50% after the age of 80 years. This table here shows the differences in presentation between the elderly and the younger adults with epilepsy. We know that auras, automatism, motor features are quite common, among the younger adults compared to elderly with epilepsy. And of course, the semiology of patients with focal impaired aware seizures are more elaborate, in the younger adults, and they are rather simpler and shorter in the elderly. However, post-ictal confusion in the elderly, usually last longer. Could be hours to days in the elderly compared to the younger adults with epilepsy. Now, diagnosing epilepsy or seizures in the elderly is not always straightforward, and it could be an Herculean task because of the long list of differential diagnoses. This could include falls without altered consciousness, which will raise the possibility of accidental falls. And of course, falls also could come with altered consciousness, again, which might raise the possibility of syncopal attack, raising the need to do EKGs and to also look at other associated factors with the fall. Now, another differential diagnosis are confusional states or memory disturbances, which again are common in the elderly. Now, if this presents acutely, of course, it could raise the possibility of toxidrome. It could be raise the possibility of drug-drug interactions, drug adverse effect, intoxications, withdrawal. However, in the setting of neurodegenerative dementia, sometimes it's even more tricky because some dementia also do have fluctuating level of consciousness, fluctuating cognition, like we have in dementia with Lewy body, or we have with some Alzheimer's disease as well. So yeah, sometimes also elderly could be delirious, because of so many things, infections, metabolic issues. And so sometimes it's difficult when we have episodic memory or confusional states, which again might raise the possibility of cognitive seizures, behavioral seizures, and all of that. Other things to consider is, that could be possible differential diagnosis, including focal neurological symptoms that comes in spells, like transient ischemic attack, or things like amyloid spells, and even migraine aura. Transient ischemic attack, usually of course vascular origin, is expected to be maximal at onset, of course, in the presence of underlying vascular risk factors and all of that. Of course, amyloid spell, be it positive or negative symptoms, will be expected to spread over contiguous, body parts, and then usually last 1 to 15 minutes and all of that. However, we know that seizures sometimes could have status epilepticus also, which could also present over the same duration. Of course, migraine aura is a possibility. However, a background history of episodic headache will readily lend this to recognition, because we do not expect a new onset migraine to start after the age of 60. So if there's a new onset hemicranial headache, of course the possibility of giant cell arteritis and all that will be raised more than the migraine. So recognizing or having an eyewitness, or recognizing and getting a good history in the appropriate clinical settings with appropriate clinical exam will help us in teasing out the other long list of differential diagnosis in the setting of consideration for epilepsy in the elderly. Furthermore, other differential diagnoses include sleep disorders, and this could be in form of REM sleep behavioral disorders, in form of parasomnias, and these are actually, very valid differential diagnosis because of some other seizure phenomenon, especially nocturnal seizures, or nocturnal ambulatory automatism, which could also mimic some parasomnias, as well as phenomena such as the periodic limb movement of sleep could also be differential diagnosis. Again, sleep-related movement disorders, non-epileptic myoclonic jerks, tremors as well, could be differential diagnosis of seizures in the elderly. And of course, we shouldn't forget that psychogenic non-epileptic attacks are also common even in the elderly. So history of psychological health-related trauma, background panic disorders, also needs to be excluded. Of course, when we talk about panic disorders and all of that, this should also be differentiated from ictal fear, which also could be a manifestation of mesial temporal lobe epilepsy. So the diagnosis of epilepsy in the elderly actually begins with quality history. I mean, in this respect, eyewitness account is very vital. Or even video recordings to be able to, look at the spell, evaluate the spells, and of course, maybe draw some points that could point to the possible semiology of the epileptic spell. And of course, the history should include the onset, the duration, the associated factor, the interictal, preictal, and all of that. And of course, should also include possible risk factors, concurrent comorbidities, medications, and all of that. And of course, examination should be careful neurological examination to exclude seizure mimics, and of course to also look at for evidence of focality, evidence of previous injury, and of course other underlying medical illness that could actually point to the possibility of existing extracerebral diseases that could also lead to episodic attack like we could have with some arrhythmias. So cardiac examination is very important. And of course, a baseline cognitive function is very important, of course, to document if there's some cognitive impairment. It's also and like we do for evaluation of new onset epilepsy, blood workup are very necessary, which will include all the chemistry. Of course, CSF analysis may be important if infection, malignancy, or if inflammatory conditions are suspected. Again, there's a role for toxicological screening or drug levels in people who are comorbid, taking other medications, and particularly autoantibody testing for new onset refractory status epilepticus, which will raise the suspicion of autoimmune encephalitis, and of course voltage-gated potassium antibodies, including paraneoplastic antibodies, could be warranted in cases of new onset refractory status epilepticus. And of course, we shouldn't forget thyroid autoantibodies in this respect as well. EEG is useful, but the diagnostic yield in distinguishing seizures and syncopal attack is quite low. Sometimes there might be a need for prolonged sleep or nap EEG, which might be revealing if the routine EEG is normal. Neuroimaging is important in this cohort of patients with epilepsy because of the propensity for localization-related epilepsy. Brain CT in particular is useful in acute situation when hemorrhage or abscess are presumed causes of acute seizures, or when brain MRI is contraindicated due to cardiac pacemakers or cochlear implants. But we know that the imaging of choice for identifying epileptogenic lesions is brain MRI. Sometimes we also do functional imaging, and we know that functional imaging provides a complementary method for localization of the seizure focus in patients with intractable focal epilepsy who are being evaluated for surgical treatment. But sometimes, when the conventional imagings are kind of non-revealing, or they show diffuse abnormality, or when there's a discordance between different modalities, then we usually will go ahead and do functional imaging, because it can provide additional information and assist in generating hypotheses for invasive EEG. The case of this 82-year-old lady with hypertension, diabetes, and atrial fibrillation, and a recent community-acquired pneumonia actually drives home the point about quickly recognizing seizures and epilepsy in the elderly, and of course promptly treating them. She had been started on ceftriaxone and sulbactam from the referring hospital, but was found to develop altered level of consciousness with fluctuating GCS during the course of the treatment. She has a background of episodic altered consciousness characterized by, blank stares, sometimes with fidgety movement of her fingers. But these events were attributed to transient ischemic attack. We scanned and our MRI showed diffuse cerebral atrophy in addition to white matter hyperintensities in keeping with cerebral small vessel disease. And of course, our portable EEG revealed biplates. Some of them were actually, quasi-periodic, predominantly on the left central parieto-occipital region. We suspected that this could be, non-convulsive status epilepticus, even from the onset. And with EEG, we went ahead and, started on levetiracetam infusion. And, this patient became fully conscious within 24 hours with electrographic evidence of, seizure cessation. Now, points to take home from this case is the fact that TIA could be mistaken for focal epilepsy. And of course, we expect generally with transient ischemic attack that hemisensory, motor deficit, or other signs of focality should be predominant. But of course, sometimes with TIA that presents with speech or aphasia without motor symptoms, again, this could be confused for epileptic aphasia. Hence, the need for EEG, for continuous EEG monitoring, or even periodic portable EEGs where that service is not available. Now, the point here again is the fact that in elderly with concurrent infections, we should be careful also with the kind of antibiotics, because some of the antibiotics like penicillin, ceftriaxone, some fluoroquinolones could actually reduce seizure threshold in patients who are predisposed. Now, if we have looked at the presentation, the peculiarity of the presentations of seizures in the elderly, the long list of differential diagnosis, another point that makes epilepsy in the elderly more tricky to treat is the pharmacodynamics and the pharmacokinetics of anti-seizure medications in the setting of aging. And one important point is the reduction in the serum albumin level, because as we age, there is a decrease in the albumin level, which also decreases drug binding. Of course, there is also impairment in liver metabolism, with type 1 metabolism more affected than phase 2 metabolism of glucuronidation, acetylation, and sulfation. Now, there's also age-related changes in GI function, which reduces the rate of drug absorption. We should also see that in the light of a decrease in the ratio of the body water to fat, reduction in the creatinine clearance, and the older people are also prone to forgetfulness. So this could actually impact drug adherence. So this kinetics and pharmacodynamics of medications and all of that actually makes the use of anti-seizure medications in elderly even more tricky. Now, when it comes to the choice of an anti-seizure medication, there are many factors to be considered. And the first factor is the seizure type. Of course, other factors should be considered as well, such as the patient's biology, how frail is the patient, and this actually takes precedence than the chronological age of the patient. Now, other considerations should include the efficacy of the anti-seizure medication, its tolerability, whether it has favorable pharmacokinetic properties, these adverse effects in the light of patients' comorbidities, and of course, which type of comorbidities and which type of medications is the patient taking, and the potential for drug-drug interaction that could affect the management of such comorbidities or even reduce the efficacy of the anti-seizure medication. Now, an additional consideration is an economic consideration, especially in this part of the world where people pay out of the pocket, and there's still a huge treatment gap for epilepsy, which sometimes is driven by the cost of the medication. So cost issues should be put into consideration. And of course, the practicality of using such medication, like the dose size, as well as the color of the anti-seizure medications, because sometimes some drugs do look alike, and in patients who have some sensory impairment or some cognitive impairment, they actually could miss color codes, and they are at risk of overdosing or underdosing or misusing the medication. However, the rule of thumb, the big rule of thumb, is to start low with anti-seizure medication, to go slow, and to aim low. This table shows the summary of recommendations for anti-seizure medications in elderly individuals with epilepsy. The truth is that randomized trials on anti-seizure medications targeting older adults are limited. However, two systematic reviews and meta-analysis suggest that lamotrigine, levetiracetam, and lacosamide are first-choice anti-seizure medications based on their high efficacy and reasonable tolerance in older adults. Now, we have guidelines from the Scottish Intercollegiate Guideline Network. We also have guidelines from the ILAE. There's a nice guideline. We also see guidelines from the American Epilepsy Society and the American Academy of Neurology. It appears that for late onset focal epilepsy, there's a level B evidence favoring the use of lamotrigine or levetiracetam based on the SIGN recommendation, and of course that gabapentin could be used as an alternative monotherapy or an adjunctive therapy, but that's a level C evidence. Again, the same idea or the same recommendation is made by ILAE in that for new onset focal epilepsy in the elderly, gabapentin or lamotrigine can be used. I mean, this is what, again, but this is just class 3 recommendation, and of course for gabapentin and lamotrigine there is reasonable level A evidence. So it appears that lamotrigine, gabapentin, and in some instances carbamazepine, which has a level C evidence, according to the ILA, are recommended. Now, of course, other recommendations like the Critical Care Services Ontario also recommended the use of gabapentin or clobazam in focal epilepsy in the elderly. Now, with newer agents available now, the choice of the initial anti-seizure medication in the elderly is evolving, and I believe that future researches will actually bring more evidence to guide the choice of anti-seizure medication in the elderly. Now, with regards to the dosing, of course, just like I mentioned earlier, the rule of thumb is to start low, to go slow, and to aim low. And in this respect, the standard target dose should be half that used in the younger adults. And when drug loading is needed, it should be performed half as rapidly compared to the younger population, so that the adverse effects of these anti-seizure medications can be minimized. Now, the goal of treatment of epilepsy in the elderly, just like in any other population, is seizure freedom without adverse effects as soon as possible. But we know that sometimes this is an ideal than what is quite practical. And of course, we know that different anti-seizure medications do have different side effects, and of course elderly also do have existing comorbidities. There may be issue with drug interaction, so the choice of medication in the elderly should be well thought out in the context of existing comorbidities and of course potential for drug-drug interaction. Now, drugs like carbamazepine or some other sodium channel inhibitor actually do have, very elaborate drug-drug interaction because of induction of the liver enzymes. Of course, renal impairment is an important consideration, especially with drugs like felbamate, gabapentin, topiramate, and of course, a lot of the anti-seizure medication also do have, cognitive side effects. So this should be considered in patients with, underlying dementia and all of that. Of course, the other issue is potential or risk for Stevens-Johnson syndrome, especially in some select populations with HLA-B 1502 variant allele, especially with carbamazepine. But of course, we also know that lamotrigine itself also carries the risk of Stevens-Johnson syndrome. Also, so these are important considerations to be noted, when the choice of medication for elderly patients are being made. Now, we know that the vagus nerve stimulation therapy is approved for pharmacoresistant epilepsy in adults and in children more than 4 years of age. But the data regarding the use of VNS in older adults currently is still quite limited. But available data is suggesting that the responder rates in older adults is similar to younger population as well, and there are no increased surgical complications when data are compared with the younger population with epilepsy. Responsive neurostimulation is a new approach to the treatment of pharmacoresistant epilepsy, which monitors brain activity through chronic electrodes, and then, of course, provides responsive stimulation to terminate a seizure when electrographic markers of seizure activities are detected. Now, we don't have so much of large data to look at the efficacy, safety, and outcome of RNS therapy in the older adults. However, we have some empirical data which currently suggests that the RNS system actually provides good seizure outcomes in the elderly, which is comparable to younger adults. And of course that it confers additional benefit of significant post-implantation medication reduction. So it will be interesting to see in the future if large data will actually quantify the magnitude of improvement provided by RNS in the elderly. Now, what about surgical resection? Data regarding the outcomes of surgical resection for epilepsy in the elderly individuals are currently limited to temporal lobe resections, although it appears that the overall outcomes appear comparable to that in the younger population. Although some authors have suggested that there is a slightly lower efficacy and potential important surgical post-surgical cognitive deficit. Again, there's a paucity of data also regarding the use of techniques such as laser ablation, in the elderly. Now, this report by Wasem et al. Compared magnetic resonance guided laser interstitial thermal therapy versus anterior mesial-temporal lobe resection in patient with mesial-temporal lobe epilepsy after the age of 50, and actually concludes that the outcome of laser ablation and anterior mesial-temporal lobe resection is actually quite similar between both populations. Elderly patients with epilepsy are often multimorbid. And of course, we know that in optimizing care in this group of patients with epilepsy, a holistic approach that targets comorbidity and seizure control is very, very important. And we know that these multiple and complex comorbidities often interact, together. They are closely interrelated, and they can impact the level of seizure control. And we also know that the anti-seizure medications also could impact the degree of management of such comorbidities. Largely, they are categorized into 6 main areas, which could be comorbidities that as a result of the underlying etiology for the epilepsy, such as brain tumor or could be dementia, or there could also be, cognitive impairment that is a comorbidity, which could be as a result of social isolation, the impact of some anti-seizure medication. Of course, there could also be other psychosocial difficulties, psychiatric comorbidities like anxiety and depression, and of course the comorbidity that is as a result of pharmacological agent, like the side effect of medications or hyponatremia that could complicate some anti-seizure medication. And of course, again, these comorbidities could be as a result of, some medical conditions or systemic illnesses that may be directly or indirectly related to the seizure. So always keeping in view the patient's concurrent comorbidity as well as frailty will actually impact, plan of management, delivering quality care, and involvement of other healthcare professionals in delivering quality healthcare to adults, older adults with epilepsy. So therefore, care coordination in elderly patients with epilepsy is a team-based approach. There should be synergy of care between the physician stakeholders, who are responsible for the management of epilepsy, in the elderly. Of course, this could be primary care physician who also liaises with the neurologist, and of course for cases that are pharmacoresistance, needing correct diagnosis, or where there's a diagnostic dilemma, or some issues of long-term medication effect and safety concern, should actually be discussed and managed, between the physician stakeholders. In this respect, the neurologist should serve as a patient advocate, and of course keep in close communication with the patient's primary care specialist, and of course other members of the care team, to ensure that the diagnosis is correct, that the seizures are prevented, and that high morbidity and mortality associated with the diseases are addressed appropriately. In this respect, the ILAE Task Force on Epilepsy in the Elderly has proposed this integrated care model for the management of epilepsy in older adults. And of course, this model involves other allied care workers and family members, and of course, caregivers, community nurse consultants. These are all important stakeholders in the management of elderly patients with epilepsy. It also guides, transfer of care or communicating care plan between hospital settings and community settings, and this allows for a smooth transition or a smooth care coordination between stakeholders who are all involved, maybe in the primary care setting or in the nursing care home or even in the emergency setting. So this two-way approach ensures that there's continuity of care, and also there is integrated care for elderly patients with epilepsy. So as I try to round up, the question then remains, how do we improve the current landscape of epilepsy management in the elderly? We know that there are gaps in current existing data regarding the management of epilepsy in the elderly. We have paucity of trials for new anti-seizure medications, and of course there's also limited clinical trials on new anti-seizure medications, as well as the fact that the existing data have smaller sample sizes, they are kind of heterogeneous, and the outcomes are sort of very short-term outcome of efficacy and tolerability. So the ILAE task force on epilepsy in the elderly have proposed that future researches, future trials should focus on outcome measures that goes beyond seizure control, looking at quality of life, looking at long-term patient-centered outcomes. And of course, there is need to conduct more researches on the dosing studies with newer generation of anti-seizure medication. Of course, another recommendation is that now we need greater homogeneity in the inclusion criteria for future studies. In conclusion, we have seen from this presentation that epileptic seizures are more common among the elderly, especially those over the age of 70, than any other age group. We have also seen that the clinical manifestations of epileptic seizures in the elderly are quite different from those in the younger patients. And in this respect, auras and generalized tonic-clonic seizures are rarer, and status epilepticus is more common. We've also seen that epileptic seizures can mimic many other clinical phenomena, and so epilepsy in the elderly often fly under the diagnostic radar, and hence improved diagnosis can be obtained by performing long-term EEGs, ECG recordings, and of course marrying those with a good clinical history in the setting of appropriate clinical setting. We've also seen that cerebrovascular disease is the most common etiology of epilepsy in the elderly. A first epileptic seizure in a patient over 60 years old is more likely due to be cerebrovascular disease. We also note that the standard target dose of anti-seizure medication should be half that used in the younger adult to limit the adverse effects of anti-seizure medication. And of course, we have also highlighted the significance of care coordination between stakeholders, and this will ensure delivery of quality care that also takes cognizance of existing comorbidities and possible side effects of anti-seizure medication to help our elderly be able to live with their epilepsy with improved quality of life. So in this respect, I would like to thank you very much for listening, and I will now welcome questions and comments.
Thank you so much, Dr. Adebayo, for that wonderful presentations. I'd just like to remind our participants that if you have any question or comments, kindly put them in the Q&A box that is at the bottom of your screen, and we're going to read them out, and Dr. Adebayo will answer your questions. So now, Dr. Adebayo, I just have a few things I'd like to address. So I know you said the focal impaired awareness are the most common seizure types that we see in the elderly, but some do tend to have generalized epilepsies as well. And most of the time, these generalized epilepsies, like we usually have them in the younger population, some attributed to them being genetic. What is the commonest attribution to a generalized epilepsy in an elderly person?
Thank you so much for the question. For generalized epilepsy in the elderly, it's almost always a bilateral spread or secondary generalization, as I will say. And of course, taking a clinical history will sometimes might not reveal the triad of auras, automatism that we clearly see in the younger population. But of course, when we investigate this elderly further, you might see, electrographic evidence of focality, and of course, even that you might be able to correlate with imaging as well. Of course, when you see generalized epilepsy, okay, especially with those who have some early onset epilepsy, like the, nocturnal frontal lobe epilepsy we used to say. Sometimes patients they are okay, and then maybe later in life they can actually, develop this. So you could see that in that setting. But most often than not, when we see, generalized, especially generalized tonic-clonic seizures that characterize a generalized epilepsy in an adult or in the elderly, most often than not, there could be a secondary spread from a focal onset.
Okay, thank you so much. And then just another question before I open the Q&A. The common question each time you're starting somebody on anti-seizure medication is, will I take them for the rest of my life? So that's a good question for somebody who's young, but for somebody elderly, well, we may not assume that they're towards the end of their life, but we know that in the evening of their life, and they will still ask that question, when do I stop taking this anti-seizure medication? So when do we consider stopping? It's easier when there's a non-etiology, maybe a tumor, or somebody has had post-stroke epilepsy. But for somebody where we cannot actually pinpoint what is causing them to develop epilepsy, when do we consider stopping the medication?
So thank you for the nice question. So the issue is it's also a very gray area, especially in elderly who still could be predisposed. And I get your point about where an etiology is not recognized, which again will raise the suspicion of some biochemical substrate, for the epilepsy. Now, the question is, when do I stop? The question about stopping sometimes should be individualized. That when the epilepsy is no longer active, and then by active epilepsy we mean this patient has not had seizures, or the last seizures in the last 5 years. But sometimes in patients who have only had you have made your diagnosis just based on 2 or 3 seizures, that are actually very closely related. Again, that is also a tricky thing. However, I would say if a patient has not had, we have decided that this patient does not have an active epilepsy, meaning there has not been a seizure in the last 5 years, I will consider stopping, the anti-seizure medication in such elderly individual.
Okay, thank you so much. We have a few questions in the chat, and I will read them out. This one is from Ala Mofak. Please, what is the period of stopping anti-seizure medication required to make the abnormality appear in the EEG? I think maybe this is similar to the question I'm just from asking. The other one is, do you also use medical CBD? I'm thinking this is the cannabis.
Cannabinoid, I think it's cannabinoid, right? Medical cannabinoids.
Yes. Mm-hmm.
Okay, I think the data we have for the use of cannabinoids in treatment of epilepsy currently is restricted to pediatric epilepsy, rather than some syndromic epilepsy. But we still do not have very robust data for its use in the elderly with regards to epilepsy. Maybe for some other conditions like pain management in people with underlying cancer or chronic pain syndrome, maybe. But of course, yes, we know that cannabinoids have very good anti-seizure properties. Whether they are going to benefit adult with epilepsy or older adult with epilepsy is another kettle of fish. So that would be my response to that.
Okay, thank you so much. Then there's this question from Asma: how to start levetiracetam in the elderly? Is it once or twice a day, as in the younger age?
Yes, please. Of course, we know that levetiracetam, based on the pharmacokinetics, is very soluble. All right. And of course, it's not metabolized by the liver. It doesn't bind to any protein, so it's readily absorbed. So it is still twice daily. But the issue is that the rate at which you titrate up might be a little bit slower. But of course, there is no the way we go is just like in the general population. I think of all the studies that we have, levetiracetam is the one that has very robust data of tolerability, especially in the older population. Care must just be taken in some older population with background behavioral abnormality because of its propensity for, aggression or even some, behavioral or psychotic thing. But again, it is twice daily, and then you can titrate up gradually.
Okay, thank you so much. I think the next question is trying to compare bevaracetam and levetiracetam. What is your experience in the elderly with those two drugs?
Unfortunately, I don't have a personal experience with bevaracetam because it's not even available where I practice. I know that some of my patients who have gone abroad to, get some of their seizures, they bring it home and they use it. Of course, being a synaptic vesicle 2A inhibitor, I will assume that they are comparable, but I do not have a personal experience with bevaracetam. So I don't know if anybody on the platform has, but personally I do.
Okay, so there's another question from Olusegun. So for this one is concerning the guidelines you had shown on recommendation of gabapentin. So how, with relation to the gabapentin, how about the risk of sedation and pause?
Yeah, I mean, that's a very valid concern for gabapentin, because of course it's a GABA enhancer. But you also should know that even gabapentin in itself, it's a weak anti-seizure medication compared to pregabalin, which is a derivative. So the concern is there, especially for those who have who have lower creatinine clearance. But again, the guideline is to start low and go slow. You might actually want to start on alternate day dosing initially before you start your daily dosing. In fact, the NICE guideline itself actually doesn't even give you a particular selection. Just say, okay, just choose any of these medications that is used in the general adult population, and then just titrate slow and go slow. So I'm aware of that concern, but again, we also know that a lot of the medication also do have sedation and drowsiness as side effect, but I would say it's a concern that can be managed with starting at a lower medication, lower doses than, or alternate day dosing than starting at a daily dose. Again, but the question, the corollary to that is that in patients with frequent seizures, in which you quickly want to attain seizure control, then that might not be your route, because then it will take you a while before you get to your effective dose. So I would rather think of an alternative rather than going the route of gabapentin.
Okay. So the next question I have for you is concerning neurostimulation. So Teresa is asking, do you ever use other types of stimulation other than the deep brain stimulation and vagus nerve stimulation as frequency-specific microcurrent?
Again, I don't have a personal experience with neurostimulation. Okay, so I will leave that to the experts. Personally, I do not have an experience with that. But just based on the data, one can assume that it should be frequency specific, because again, when you have epileptogenic discharges, all right, of course, sometimes it comes at a very specific frequency, and there could also be subharmonics of those frequencies. So I would think that the setting will be based on the primary, frequency, and as well as the subharmonics of those frequencies. But again, I would think that the expert will be more attuned to answering that question.
Okay. I think this is more of a comment from Eddie, where he says he tried 15 years after surgery and he worked and he still had to go back on Keppra for life because the status epilepticus happened 6 months after going off all drugs. but this was also related to kidney infection. I think that's just a comment on maybe stopping anti-seizure medications. So the other comment, it's surprising to see clobazam on the Canadian recommendation for elderly subjects. What are your thoughts about the risk of falls with benzos?
Yes, risk of fall is there. Risk of cognitive impairment is also there. But it is what it is. It is what's in the recommendation. It's again, it's not one route I will go because of the risk of cognitive impairment in the elderly, which again could predispose to falls as well. But I think in these days that we have so many medications that we can choose from, I think we're in a better position compared to the previous generation. But again, rule of thumb is rule of thumb, and I think that there is no safe haven, as it were, because again, treatment is individualized. I think that would be my response to that. But I think it's a very valid concern. And I think we need to look at that.
Okay. So this other question, if a patient is suffering only from seizures, but tests do not confirm epilepsy, and still doctors are prescribing medications of generalized tonic-clonic seizures to the patient, is it good to prescribe the medications for a longer time without confirming the diagnosis of epilepsy?
Okay, now, let's go back to diagnosis of epilepsy. It's actually a clinical diagnosis, all right? It's a clinical diagnosis in the setting that if you must have these seizures, of course, again, two or more seizures, 24 hours apart. Now, the question is, are the spells epileptic? Okay, I mean, maybe that's the first question. Are the spells epileptic? And of course, we've considered so many things to look at, looking at semiology, eyewitness account, videos, because sometimes EEG could be non-revealing, especially if they are inter-ictal EEG. And that's why sometimes we recommend that there should be prolonged EEG. And of course, the more prolonged the EEG, the better the yield. I think that's the recent practice. That you should have both awake and asleep EEG to be able to confirm if those spells were actually epileptic spells or some other paroxysmal attack that are seizure imitators. So the issue is, but if it's seizure, two or more seizures 24 hours apart is epilepsy. I mean, it's a clinical diagnosis. So now, is it still good to prescribe anti-seizure medications because patient is only having seizures? Yeah, I think that should be the guideline. But if there is a doubt about the diagnosis, then there should be a revisit, or even get a second opinion about, confirming the diagnosis. Because sometimes, psychogenic non-epileptic attacks also mimic epilepsy, and so I think the first thing when diagnosis is in doubt is to go all the way and confirm diagnosis. And that's when diagnosis is confirmed, then of course it is better and safer to start on anti-seizure medication.
Okay. The next question is from Musowa Singoi. In the case of using carbamazepine in the elderly, how should it be started and titrated upwards? Is it necessary to start once daily dose and then go to twice daily, or should it just be started at a twice daily dose based on the pharmacokinetics?
Yes, I think I mentioned that in passing, that of course and this is not only about carbamazepine alone, but is a general rule of thumb to start at a lower dose and titrate as half the rate as what you would do in the elderly. Of course, we know that carbamazepine itself is notorious for autoinduction. So again, it's also not would be my first line drug to go to if I need for someone with very frequent seizures, right? But of course, in elderly, to limit side effects, if you choose to use carbamazepine, because again, in sub-Saharan Africa, that is what is almost always available in every nook and cranny. Some of the newer anti-seizure medications are not readily available. But I would recommend that you get the control release, because that sometimes limits the, side effect profile and all of that. So yes, you can start at a once daily dose, and then you can gradually titrate up if you have enough time and seizures are not that frequent, then you can titrate up and then go to twice daily dosages and then take it from there.
Okay. I think this is a comment. It says the challenge with medical CBD is that it increases the active metabolite of the most common second drug used, clobazam, amplifies its effect 3 times, and other things such as melatonin. However, I share as this greatly reduces seizures but needs close medical supervision because similar to other anti-seizure medications, at too high a dose can cause aggression or amplify already existing anxiety disorders. Yes, levetiracetam also often causes aggression, and these examples I'm sharing are from my own personal experience. However, using benzodiazepine with medical CBD, from my own experience, was the most beneficial combination, and it's a shame it is only used in severe cases, maybe because of its expense. However, I found for myself personally that this combination has been shown to work the best. So this is from Teresa in Austria. So that was mainly a
I think
comment.
it's very, very, very important. And I think
Yes.
that comment is noted. Thank you so much.
Okay. I think the next question, epileptic seizure aggravated by ejaculation of sperm cells during sexual intercourse. How will you treat this?
No different from any other epileptic seizures. All right. Of course, there could be orgasmic seizures. Okay. There could also be, sexual auras, that could actually be precursor to generalized tonic seizures, especially we are dealing with prefrontal cortex seizure origin. But again, the treatment is no different from any other epileptic seizures. As a matter of fact, how frequent are these attacks? Of course, I mean, you really want to protect the patient as well. So it's no different from any other seizures. I'll treat them the same. Prevent a recurrence, prevent seizure happening, give prophylaxis, anti-seizure medication. That's the way to go.
Okay. I mean, how do lifestyle factors such as diet, exercise, and sleep patterns impact the management of epilepsy in the elderly patients? And what interventions can be implemented to promote a healthy lifestyle and improve seizure control in this population? This is from Halima Musalam.
Yeah, thank you so much. I think lifestyle changes is very important. Okay, with managing seizures, good sleep, regulated sleep, diet. Of course, diet means just a balanced diet, good rest, and that's why we are counting on caregivers, family members, to be part of the management team for the care for older persons with epilepsy. Exercise is important, especially supervised exercises, okay? Because again, exhaustion, which will come as a result of, exercise will actually be a seizure precipitant. Sometimes, we used to restrict swimming, but again, not entirely if there will be a partner with you. But of course, very risky sports, again, is restricted. However, the point is good sleep pattern, reduction of stress, good hydration, early treatment and recognition of infection, limit alcohol use, or complete cessation, are very good lifestyle management, especially in patients, this population of patients with epilepsy. So yeah, it is something that should be emphasized, especially to family members or caregivers of older adults with epilepsy.
Okay. Can health insurance cover epilepsy drugs cost if you want to live and work in other countries?
Now, there are different legislations across countries, across continents, even within the same continent, there are different legislations. And of course, within some countries across states, there are also different legislations. So I think the individual should just confirm what obtains from where it's coming from. Sometimes a comprehensive medical report could assist, but I'm not sure if there is a universal protocol or guideline from health insurance companies. Some will not cover any chronic disease, beyond certain ages. I mean, of course, for obvious reasons. And of course, epilepsy is a chronic condition, which falls within that bracket. So, but I think the question would be better, addressed to if the person knows the legislations of or health insurance coverage and reimbursement specific to the location.
Okay. I also have another question. Looking at Africa as a continent, especially sub-Saharan Africa, we tend to have a diagnostic challenge in terms of epilepsy diagnosis, of course, and also access to EEG facilities. So if, when you look at the elderly, when you think they're having seizures, or maybe they come in status epilepticus, and you want to ensure that you've treated them adequately, you don't have an EEG to make sure maybe they're not having non-convulsive status or they're not having any subclinical seizures, but that's often difficult to say. And it's also difficult to see if you should titrate your medication upwards or leave them at that dose. I don't know what your experience is. What would you do?
Unfortunately, I'm not. Unfortunately, I'm not in that situation. But I understand the dilemma that sometimes it's very difficult. But I think that's where neurology is interesting, because sometimes, if you look keenly, you might want to rule out other more common things. And then sometimes if you are in a place where you have no access to EEG services, continuous EEG services, EEG monitoring, it's tough. But you must just see if everything has been excluded, and then you want to start to titrate. But again, it's very difficult, because even when diagnoses of status epilepticus are made, again, it's not easy to say this is when I want to stop. Okay, and for us, like in my center, we don't have a continuous EEG monitor, but we have the facility to have a prolonged monitoring in the ICU, where we can titrate our anti-seizure medications. Of course, we use our portable EEG, and then we use that as well to see if patients are responding. For example, the case that I shared was one of such a case that we managed last year. And of course, we were able to do a continuous, periodic portable EEGs until she became, electrographically seizure-free. And then, of course, so it's difficult, to be honest with you. It's kind of difficult. For convulsive status epilepticus, that's easy, right? You know that, yeah, when I'm no longer seeing the jerks, when I'm no longer seeing tonic, yeah, I think my seizure is controlled. But now when you have, very long period of inactivity, again, you want to see, have I attained my burst suppression, or what is going on? So I think the place of EEG cannot be overemphasized. And I think one of the things we need to advocate for is increased access to EEG services. Just like we have in ECG. I mean, there's ECG everywhere. Why is EEG not everywhere? I think we need to just make more noise from the epilepsy and neurology side of things.
Okay. Thank you so much. Just one more comment with regards to epilepsy surgery. In the elderly, especially those above 75, is it really worth it to go in and actually resect, do a lobectomy or something? What's your opinion? I know you really can't tell when somebody is going to die, but if they're already in the evening of their lives, is it worth it considering the complications that may arise?
I think the thing is, again, we don't have data for the very elderly. Okay, we have data for anterior temporal lobectomy in patients with over 50 with temporal lobe epilepsy. But of course, in this part of the world, sometimes we do lesionectomy. You just go remove the lesion, you go remove the tumor, you go remove the meningioma. That in itself does not qualify, in my opinion, as epilepsy surgery, because you are not resecting, as it were, an epileptogenic focus. Of course, the tumor could be an epileptogenic focus and all of that. Now, sometimes family decides that this is what they want. In Africa, we have a kind of paternalistic kind of, issue that we want to decide. The family decides for the patient. So, okay, no, just leave our dad alone. Let him die in peace. So, and of course, now we have emphasized that the family members are also important stakeholders in management. Yeah, that's nothing you want to do. If somebody wants, I want my dad operated, of course, yeah, if the dad gives a go ahead, operate. An example that readily comes to mind is about a patient I've been following up now for almost 6-7 years, who has a meningioma. Of course, she also has some other cardiac issues, but she's quite stable. And she's come in with 2 or 3 breakthrough seizures at some point. But she said she doesn't want surgery. The relatives said they don't want surgery. So we just, okay, now take your drug. We're going to titrate up. And as I speak, she's still fine. I mean, she's been seizure-free for quite a while. So is it worth it? I don't know. It's difficult for me to say. But again, it depends on what the family wants. But I think true, epilepsy surgery is kind of very rare in this age group. But there are lesionectomies. So if there's an abscess, you just want to go there and drain it. Sometimes if there is a cortical met, you may want to just, okay, maybe it's worth removing this cortical metastasis and all of that. So I think decisions should be individualized.
Okay. Thank you so much, Dr. Adebayo. I don't see any more questions in our Q&A box. So if there are not any more questions or comments, I'd like to thank Dr. Adebayo for sparing his time to share with us his knowledge on epilepsy in older people. It's really been a great time interacting with you. So for those joining us, this is Dr. Adebayo from Tanzania, and we thank him very much for this wonderful webinar. I just want to make mention that on the ILAE website, we have a global health in epilepsy project database that we are encouraged to fill in if you're carrying out any project. So just in information on this global health database, it provides a registry of existing epilepsy protocols or projects throughout Africa, the Eastern Mediterranean, as well as even in other regions. So it's a global one. So it identifies information such as project location, institutional partners, project scope, funding sources, and volunteer needs. This database is quick and easy to complete. If you go on the ILAE website, when you submit information on your project, you inform understanding of efforts that are occurring throughout the world to narrow the epilepsy treatment gap. So the database will provide you an opportunity to learn from others and also to explore collaboration opportunities that might strengthen your own work as well as that of the sector. Furthermore, the database will allow people from different areas such as government, academia, non-profit organizations, or philanthropy to learn about existing efforts while offering a means to engage. So on the next slide, after this webinar, please scan the QR code to receive your certificate. I think there'll also be a link in the chat box to the certificate. So just look out for it. Thank you so much, Dr. Adebayo, for joining us this evening. Thank you to all the participants that joined in. Please don't forget to complete the survey for you to have your certificate. Thank you and have a good night.